After an enriching and insightful session on growth charts, we now move on to our next session, that is Symposium on Diabetes, which promises to be equally compelling. To guide us through this session, we have two esteemed chairpersons with us. First, we have Dr. Ezrianti Binti Anwar Ziani from Malaysia. She is consultant pediatric endocrinologist working in University Malaya, Kuala Lumpur, and her areas of interest are growth, puberty, and diabetes. And we have Dr. Anna Simon with us from India. She is Professor, Department of Pediatrics in Christian Medical College, Vellore. Her areas of interest are thyroid, puberty, and adrenals. It is my pleasure and privilege to welcome both of you. I would now like you to be kindly take lead of the sessions. Thank you very much.
Good morning. So we are moving on to the next session, which is a Symposium on Diabetes. And we have three eminent speakers today, and I hope you will all really find this very useful.
All right. Good morning, everyone, and I hope everybody is all up and set for the next symposium. Thank you for being here in the last day. So we are looking forward to the next talk. I would lovely to invite and introduce you to our next speaker, Professor Dr. Joseph Dang from Vietnam. He is currently the Deputy Chair of the Pediatric Division, Department of Clinical Medicine, Hanoi University of Public Health, Department of Pediatrics, Department of Biology and Medical Genetics, Hanoi Medical University, and obviously from the Department of Pediatrics, School of Medicine and Pharmacy, Vietnam. He has fantastic reputation in Vietnam. Thousands of citations. I just looked into his profile just now, and we're really looking forward to your topic today, Professor. So the floor is yours.
Thank you. Thank you very much for your kind introduction. Good morning, everyone. First of all, I would like to thank the organizer for inviting me to talk about monogenic diabetes topics. I'm going to talk about conceptions, categorize, and molecular mechanisms of monogenic diabetes. But most important part is diagnosis and management of monogenic diabetes. I will highlight on neonatal and infancy onset diabetes and maturity onset diabetes of the young, or MOD D. In 2022, ISPAS published consensus guidelines for diagnosis and management of monogenic diabetes in children. As you know, monogenic diabetes refers to diabetes mellitus caused by one or more defects in a single gene or chromosomal locus. It is inherited as dominant recessive X-linked or non-Mendelian traits or de novo mutations. That is uncommon, and the appropriate treatment is determined by etiology genetics. Monogenic diabetes is categorized into four groups. First is neonatal diabetes, that means diabetes diagnosed before 6 months, or early infancy diabetes. In this group, we classify into two subgroups. Permanent or transient. The second group is MODY, and further is diabetes associated with extra pancreatic features. In this group, 18 genes contributed to genetic etiologies. The last is a monogenic insulin resistance syndrome. This slide shows molecular mechanisms of monogenic diabetes, including mutations in genes to develop pancreatic beta cells and potassium channels, including ABCCH and AKCJ11 that I will explain after, and GCK and genes of transcription factors. When we order genetic testings for monogenic diabetes, first situation is that diabetes diagnosed before 6 months or between 6 to 12 months of age, but negative autoantibodies testings or other features of associated with monogenic with diabetes. We test for neonatal diabetes. In second situation is patient with diabetes or hyperglycemia before 30 years. In this case, if we diagnose as type 1 diabetes but lack evidence of autoimmunities or family histories of C-peptide is positive after 3 years of diagnosis, or clinical diagnosis as type 2 diabetes, but absence of severe obesity or family histories of no obese diabetes. We move for test for MODIs or syndromic diabetes if MODI is negative. Further group is diabetes with syndromic features such as hearing loss or neurological features. We test for syndromics or mitochondrial disease. Last group is persistent fasting hyperglycemia but mild. We test for GCK. If negative, we move for multi gene testing. This slide shows in more detail in case with type 1 diabetes diagnosed, we treat with insulin. In that case, we test for C-peptide. If C-peptide was positive, we test for antibodies. If negative, we move for genetic testing using next generation sequencing. If no mutation is fine, we move for whole genome sequencing or polygenic risk score testings. In single gene testings based on clinical phenotypes, we order test for specific genes, and after confirmations, we move for management. But nowadays, next generation sequencing is available in many countries, and with case poorly defined early clinical phenotype, we move for test for unknown genes and then identify genetic etiologies. After that, we predict phenotypes and also move for appropriate management. Now I'm talking about neonatal and infancy onset diabetes. This group is very rare and prevalent is 1 in 1,000 live birth, and the majority of cases we have monogenic etiologies. Mutation in genes lead to abnormal pancreatic development or abnormal beta cell functions or restrictions of beta cells. This slide is not updated, but you can see here's data from over 70 countries sending samples to Esther in UK for neonatal diabetes testings. You can see here in 2000, only 4 genetic causes was identified, and we could just explain 10% of cases for neonatal diabetes. And after 10 years, 14 gene was identified, and we could explain for 50% of cases. But this year is already 39 genetic causes was identified, and we can explain 91% of large cohorts of 2,512 probes. Among these 8 genetic causes, explaining 98% of pancreatic agenesis cases. We contributed 1 family for 1 new gene. We will show in next slide, and already published, and 1 more genes now under studying protein function. They asked us to keep secret because not yet published. This slide shows etiologies of large cohorts of 700 children with neonatal diabetes in non-consanguineous parents. You can see here most common is potassium channel, and next cause is INS. However, in consanguineous population, you can see the most common is one-coat syndrome, one-coat Harrison syndromes, and potassium channel is rare. This slide shows a database of genetic causes of neonatal diabetes among 1,020 cases from 79 countries. You can see here the potassium channel accounts 46%, After identify genetic etiologies, we can predict phenotype. For example, in case with 6q24 imprinting abnormalities confirmed, we can predict diabetes remissions at the middle age between 12 to 14 months. But we should pay attention because diabetes we relapse in 85% around puberty. I'm moving to show you some cases in Vietnam. First cases is a second child of the families at 45 days of age. She presented with fever and polyuria. On admittance, we recognize lethargy and bunching fontanelle. Based on clinical symptoms, we found that blood glucose level was very high, 47, 49 millimole per liter, and pH was low. And also brain CT shows intraventricular hemorrhage. We identify mutations in KC and J11 mutations, and we gave her insulins and also surgeries for ventricular peritoneal shunt. After confirmations of mutations in potassium channels, we transfer to sulfonylurea, and we were successful after 2 weeks of transferring. She came every year for diabetes support group meetings. Last time, Professor Margaret came to Hanoi. Now she came to give us things, and now she is a second year student of Art University. This slide shows mechanisms of activating mutations in potassium channels. In this case, ATP does not cross potassium channels. You can see here is among cases with KCNJ11, 90% was permanent neonatal diabetes, and 10% was transient neonatal diabetes. In case with ABCC8 mutations, 66% was permanent neonatal diabetes, and 34% was transient neonatal diabetes. When genetic testing was confirmed, we could transfer to sulfonylurea, and literature showed that 90% of cases was successful from insulin to sulfonylurea to improve glycemic management and minimal mild hypoglycemia, because sulfonylurea closes potassium channels and leads to insulin secretions. This slide shows our data. Our database including 58 cases with neonatal diabetes. First, we perform Sanger sequencing for common etiologies. If not mutations was found, we move for analysis of chromosome 6q24 imprinting abnormalities or specific genes. If not abnormalities was found, we move for panel next generation sequencing and identify some causes. On this is not mutation was identified, we move for whole genome sequencing, and we can identify new genes or new phenotypes of neonatal diabetes. We published our data of 70 cases during 13 years. We identify mutations in 78 cases, including 10 cases with mutation in I and S. However, most common you can see here is potassium channel mutations, and also 6q24 imprinting abnormalities. After confirmations of potassium channels, we transfer to insulinurea. This paper we published 27 cases which transferred to sulfonylurea, but just 26. But one is transient diabetes. We successful for on cases. You can see here is HbA1c with insulin treatment and also sulfonylurea is much better than insulin injection. Same tendency you can see here is for glucose level with sulfonylurea is much better than insulin and stable. With insulin, you can see here is crazy. I'm showing you second case in Vietnam. That is at 2 months of age, she presented with convulsions, and at local hospitals, they tested blood glucose level, and it was high 23 millimole per liter. Transferred to our hospitals, we tested again 42 millimole per liter, and pH was low. But on admissions, liver function still normal, but during stay at the hospital, she had jaundice, severe jaundice progressively, and you can see here is liver function, this liver functions. But she's still lucky. We gave her insulin, and last visit she was normal development and normal liver functions, and HbA1c was 7%. We confirm one cause Rarison syndromes due mutations of these genes. This slide shows for the case that we make diagnosis neonatal diabetes at 2 months with TKA and diarrhea, hypothyroidism, and immune deficiencies. We identify mutations in FOXP2, FOXP3, that is IPEX syndromes. But with families, it's so complicated. This is phenotype is neonatal diabetes, but two different boys, you can see here, this case was diagnosed with diabetes at 5 years old, and this guy was diagnosed with diabetes at 6 years old. But this combined with hemorrhage, gastric intestinals, and he died at 70 years of age because she refused taking immunosuppressor. But for this, he presented with recurrent pneumonia and dependence on oxygen therapy, stay at the hospital for 2 years, and after confirmations, we gave him immunosuppressor, and just after 2 weeks, he was discharged from oxygen, and also he could move normally. For IPEX syndromes is caused by mutations in one of 9 genes, but our case is mutations in FOXP3. We should be consider these conditions if male infants present with diarrhea, eczema, autoimmune diabetes, or immune deficiencies and severe infections, and we should test for FOXP3. As studies, my colleague sent me results of FOXP2 mutations, but it's not at diabetes. We should follow up for future that case without diabetes with FOXP2 mutations. For treatment of this case, we should use immunosuppressor agents such as sirolimus or steroids. Now I'm showing you a case, new cause of neonatal diabetes and new phenotype of gene mutations. The gene EIF2B1 was reported as a genetic cause of leukodystrophy, but in this study, we performed genome sequencing for 44 probands with diabetes before 6 months, and also with replication studies, including 188 cases, children with diabetes before 2 years. For this group, we already excluded 25 no genetic causes of neonatal diabetes. We identify mutations in EIF2B1 in 5 cases. 4 or 5 patients had hepatic-like episode in childhood. Based on these studies, we concluded the novel EIF2B1 mutations as northern causes of permanent diabetes and liver dysfunctions. This is case we contributed to the studies. At 4 days of age, we diagnosed neonatal diabetes. Also, you can see here liver dysfunctions. But at 10 years, 4 months, we check again, but just one time, short periods of liver dysfunctions. Now the liver function was normal and HbA1c was 6.5. And mutation we identify is the novel pathogenic variants. After publications, we have one more case is at 4 months, 18 days. He presented with liver dysfunctions with 2 causes. You can see here, GOT and GPT was very, very high. And also, we perform MRI, brain MRI at 3 years of age. It's normal. It's not local dystrophy as classical literature. And we check again HbA1c that was 7.8% 2 months ago. We identify also the novel pathogenic variants in these genes. Now moving to maturity onset diabetes of the young. Yeah, this is non-immune dysfunctions of pancreatic beta cells and early onset non-insulin dependent diabetes mellitus usually presents before 25 years. It is inherited as autosomal dominant and absence of metabolic syndromes. The prevalence is 1 to 6% of all cases of diabetes mellitus. This slide shows molecular mechanisms of MODY. You can see here mutations of many transcription factors and also GCK and now also potassium channels cause MODY. How is common of MODY? Next generation sequencing for cross-section studies for 1,564 probes from 116 endocrinology departments. We could identify pathogenic variants in 254 cases. That means 16%, and even higher, 23.2% in oral Caucasian patients. Yeah. I show you 2 cases from our cohort. First is 9-year-old boy. He has no obesity, but the father was diagnosed as type 2 diabetes. At home, family tested the blood capillary glucose. They recognized mild hyperglycemia, but persistent. They transferred to our hospitals, and they was so stressful, and we gave him very low insulin and continue to check blood glucose level. And we use CGM, and just 1% is high hyperglycemia. And then we move for genetic testing. We confirm pathogenic variant in GCK. After confirmation of genetic etiology, we stop giving him insulin and also send him home. The second case is a 14.5-year-old boy. 3 days before admission, he presented with vomiting, abdominal pains, and lethargies. On admissions, we recognize dehydration and plasma glucose level was high, so high, 90%, 97 millimole per liter, and HbA1c was 20.4, but that was first admissions. And also pH was low. You can see here creatinine concentration was very high. And based on this, we perform ultrasounds and also CT scan for abdomen. We recognize no pancreatic bodies and tails, and also some cysts at the kidneys. For this, we move for genetic testings for modify and confirm mutations in HNF1B. But we still use insulin for this case. This slide shows list of MODIs. You can see here most common is MODI3 and MODI2, and after that it's MODI1. MODI5 is rare. On this MODI is due to beta cell dysfunctions. And also this slide shows MODI12, MODI13, you can see here potassium channels mutations. You can see that contributors less than 1% of MODI cases. This slide shows most common of MODI, especially clinical features and treatment. With GCK mutations, we don't need treatment. But for MODI2, MODI1, and MODI3, we should use a low dose of sulfonylurea. For MODI5, we need to treat with insulin. But for MODI12 and MODI13, due to mutations in potassium channels, we have to use high dose of sulfonylurea. This review was published in 2024. It was written based on ADA and European Society of Studies for Diabetes. They wanted to give strong evidence for precision treatment of beta cell monogenic diabetes. I just have enough time to show GCK-related hyperglycemia. 10 studies to assess stopping anti-hyperglycemic agents on HbA1c or glucose, or assess the stability of HbA1c over time on no therapy. In 175 patients from case report or cohort data, the time of follow-up between 3 to 126 months, plus with 35 patients after cessations of pharmacologic therapies following genetic diagnosis. On study show that stabilities of HbA1c with no significant change, including when glucose lowering therapies of either oral hypoglycemia agents or discontinue of insulin. The single larger cross-section cohort studies of 799 cases show that no differences in HbA1c between observational non-randomized treated and untreated group. Now moving to last slide. In summary, monogenic diabetes is diagnosed in any age, especially in neonatal period, childhood, and adult. The diabetes is isolated or associated with other features. The corrected diagnosis is essential for clinical management, predicting disease progressions or preventions using testing for other affected and at-risk family members. The genetic testings for diabetes for children less than 6 months of age or children associated with other features suggestive of monogenic symptoms is recommended. For on-at-the requires selections from a sea of common polygenic type 1 or type 2 diabetes based on age, BMI, treatment, and family history, combined with biomarkers such as antibodies or C-peptides. Now we move for next generation sequencing to analyze the unobserved monogenic diabetes genes in a single assay. Even we can identify new candidate or new genes of monogenic diabetes. I would like to thank Professor Sian Ela and her team at Esther University. Professor Maria Grape, she came to Vietnam every year. This picture shows she was giving lectures, epidemiology classifications and diagnosis of children with diabetes. And also with on staff of our team, they work so hard. And now we are performing 3 clinical multi-center clinical trials. One of them is congenital hyperinsulinism using antibody. During 1 year, 17 countries just collected 26 cases, but from 1 month we screened for 12 cases and we give injections for 4 cases. Thank you very much for your attention.
Thank you, Professor Joseph Doon. Please take your seat on the stage while we will invite the next speaker.
After we come back.
Thank you, Professor Joseph. Professor, you can sit on the stage. Okay. All right. So without further ado, I'd like to introduce to our next speaker, Associate Professor Ryan Paul from New Zealand, all the way from New Zealand. I'm sure you have overcome your jet lag by now? Okay, that's good. All right, we welcome you on the stage today. Associate Professor Ryan Paul is endocrinologist at the Health New Zealand and University of Waikato. He is also a clinical associate of the Maurice Wilkins Centre, the immediate past president of New Zealand Society of Endocrinology, executive member of the New Zealand Society for the Study of Diabetes, and convenes the New Zealand National Diabetes Guidance Group. Professor Ryan's research interests are in the use of technology in diabetes, management of diabetes in the youth, emerging adults, and education of diabetes for health professionals. He was actually awarded by the New Zealand Medical Educator of the Year in 2019. So the floor is yours, Professor, please.
Thank you for the kind introduction and for the invite. I've brought the whole family and we're having a wonderful time in beautiful India. My biggest disclosure is I'm an adult endocrinologist. It may seem foreign in this room, but I do a lot of work with young adults with diabetes, and I'll talk more about that as we go along. The reason why I enjoy talking about this topic is understandably diabetes technology research is focused primarily on type 1 diabetes, and there really remains a strong entrenched bias about the potential benefit of technology in other forms of diabetes. We all know the challenges of the limited funding we have for diabetes technology worldwide, even more so in type 2 diabetes. As Bob Dylan sung, the times they are changing. It may be slow, but things are gradually progressing. So the areas I'm going to focus on today mainly be on CGM and a wee bit on pump therapy, as well as some other aspects of technology. So we'll start with CGM. And one of the biggest questions I get is, why do people with type 2 diabetes actually need CGM? And the reasons for this is we know that probably at best only half our people with type 2 diabetes are often meeting their glycemic targets. I think one thing that's really underappreciated is the rate of hypoglycemia in people with type 2 diabetes treated with insulin. Now, this is mainly for more elderly populations, but at least 2/3 of those who are elderly are having overnight hypoglycemia, which is missed on self-monitoring, and about 1 in 5 people with type 2 diabetes on insulin and or sulfonylureas have at least one episode of severe hypoglycemia per year. Now, if you look at age-matched data, which is much more relevant for our younger population, you're probably looking at about half the amount of those with type 2 diabetes and those with type 1 diabetes are having episodes of hypoglycemia, so it's not insignificant. And the other aspect is we really do know that awareness of the health literacy in our population with type 2 diabetes on the effect of lifestyle and medications is really low. And what about in youth? I mean, that's our main focus for today. We already know from this meeting and from the extensive literature that the prevalence is exponentially increasing of type 2 diabetes. We know that type 2 diabetes in youth is a different beast. It's far more aggressive. It's far more progressive. In fact, in many countries, your diagnosis of type 2 diabetes in youth has a far worse prognosis than type 1 diabetes. It's something we really do need to focus on. We also know there's a greater need for insulin therapy in youth with type 2 diabetes. It's more progressive. We've got far less treatment options. We also know that for those on insulin in youth, actually monitoring is often far more difficult in this group, and many have high HbA1cs, high glucose levels. So what is the evidence for CGM in this group? And there's actually surprising little high-quality data. In fact, last year, there's only 11 published RCTs in type 2 diabetes. But what they did show was for those that both on insulin or not on insulin, there is an improvement in both time in range and a decrease in time below range and time above range. It is modest. We're only looking at about 0.5% reduction in HbA1c on average. And if you look at the RCT data of intimately scanned CGM, there is no evidence of benefit, and that is really relevant in a population like India, where the free Solibra-1 is the mainstay of CGM. What is important, though, in countries where CGM isn't funded, is that there are benefits from intermittent use, and it does not have to be continuous. And there is also associated positive lifestyle changes. You know, that's still the mainstay of treatment of type 2 diabetes. And there's reduced clinical inertia, which probably remains our greatest barrier in treatment of type 2 diabetes worldwide. There is also now emerging data that those benefits are also seen in youth in terms of the improvement in behaviour change. And now there's been a new focus where CGM is available, that it's likely as effective as adding another glucose-lowering therapy. So instead of perhaps starting a GLP-1 agonist, you'll start CGM instead. You still get that roughly just over 1% reduction in HbA1c potentially. And what we do know is evidence of benefit is if you stop the CGM, the glucose levels go higher again. It is well tolerated in type 2 diabetes. We shouldn't assume that people don't use the CGM. They pretty much wear it 100% of the time. But the real major limitation here is the lack of decent data in youth. More than that, though, and I'll talk about those limitations, is that we've mainly focused trials in mainly white populations with fair glycemia, and it really leaves bigger questions about the other populations. But what we do know in initial data in youth, that the benefit of CGM appears to be at least that to our adult population. I spoke about the limitations. The other big limitation is that typically studies have only gone with CGM for a few months or 6 months at best, and really had little optimization of medications in between study visits. And remembering that for all of our people with diabetes, doesn't matter what type of diabetes they have, they spend probably at least 99.9% of their lives outside of contact with their health team. So what that led us to do is to develop the To-Go CGM study, and the initial RCT phase is recently published in Diabetic Medicine. But this is just a one-to-one, real-time versus SMBG using the Dexcom G6 initially, and all those in the control group crossed over at 12 weeks to then switch to CGM. And we're aiming to go for this trial as long as possible. In fact, we've secured funding for at least 5 years, which has been great to really see that long-term benefit. We also used, this is pretty much all led by diabetes nurse specialists in terms of doing the study visits, with a self-titration plan for insulin for people with diabetes in the meantime. And there's Claire and Rach at the top who have been leading this study. We took all those with type 1 diabetes and HbA1c well above target and at least a moderate dose of insulin, and we really targeted recruiting high-risk groups. So in our demographics, at least half of our population was Māori, who are the indigenous people of New Zealand. You can see a very high mean HbA1c. They're of close to 10%. And by New Zealand standards, most of the study participants from the lower 30% socioeconomic deciles. Almost all had never seen a CGM sensor before. So we're really starting from scratch. What the study showed, we had a marked reduction in HbA1c, in terms of close to 2% in the intervention group, and a 16% increase in time and range, and improved glucose levels across the whole day. So what we do have the intervention group in blue and the control group in red, but what we do show here is that most of that improvement in glycemia was overnight. It's providing that reassurance that no hypoglycemia overnight with that increase in nighttime insulin. Here we have, these results also show the extension phase. So in yellow, we have those that on CGM, and in blue, we have the control group, which switched over at 12 weeks. And what the main take-home message from here is that the benefit of CGM was seen within 2 weeks, and it persisted up to 6 months. And I can tell you right now, for the extension phases, it's persisted out to at least 18 months at present. This is it can be an unusual graph on face value, but what this powerful message showed was that the improvement in CGM was throughout all groups. It didn't matter what age, what ethnicity, what socioeconomic deprivation, whether on GLP-1 or SGLT2 or not. It was CGM was the benefit in all. And this also led to another change of tack, but another project where we took this a small pilot study of 23 young adults with type 2 diabetes. Once again, their mean HbA1c was well above target, at 80 millimole per mole. Almost all participants were Māori. And we used intermittently scanned CGM over a 3-month period at the beginning and at the end of the period. And we used a Kaiwhina or a health navigator to work with the families and really had family-based education and support. And what we showed was, once again, a dramatic reduction in HbA1c by roughly just over 2% that persisted for up to 6 months. And that's led to now we've got a large RCT underway to try and delineate what the effects were. Was it CGM? Was it the health navigator? Was it other? And what I can tell you from the initial results, what it appears, and this is also from the to-go CGM, because we've done a lot of qualitative work with that, is actually the main benefit seems to be of CGM is increasing adherence to medications. There is benefit also on diet and lifestyle as well, but it really is about showing the benefit of the CGM and getting people to take their medications has been the mainstay. But what about CGM and other types of diabetes? So as you expect, there's very limited RCT data in non-type 1, non-type 2 diabetes, particularly in youth. But we do know, I guess, most of you will be very familiar of the role in cystic fibrosis-related diabetes. There is quite likely a clear benefit in monogenic and mitochondrial diabetes for those who are insulin deficient. In fact, there's more evidence coming out about, particularly in areas where you may not have access to multi-gene panels, about CGM identifying the different glucotypes to let you select what gene panel you're going to go for. So with that evidence, what is the current guidance for funding for CGM worldwide? Well, this is from the ADA, and the EASD has similar guidance, basically not differentiating between type 1 and type 2 diabetes. If you've got diabetes on insulin, we're recommending CGM. Ideally, that's as early in your diabetes journey as possible and from diagnosis if possible. And if you cannot access continuous glucose monitoring, then going for intermittent use if that is possible. ISPAD, just due very reasonably, so with the lack of data in youth, our recommendations consider CGM in that group. But what does the funding represent for this? Now, I think Japan's got it right, which is great in terms of if you are on at least one injection of insulin a day, you've got access to CGM. You do have to jump through loopholes in the US and UK to access CGM. In Australasia, and obviously in many countries throughout Asia and Pacific, including India, there is no funding of CGM for type 2 diabetes or other forms of diabetes. which leads me on to something I'm very passionate about, is the inequities that we create in access to technology. I think that's one of our greatest challenges we have in healthcare professionals. This is data we've published in The Lancet, but also data that we used to campaign to our funding bodies to fund CGM for type 1 diabetes in New Zealand. We've only got it this week. It is a momentous occasion in our diabetes care in New Zealand. But what this showed, this is for all children with type 1 diabetes in New Zealand, that non-funded use of CGM was much lower in our Māori and Pacific peoples, so our Indigenous peoples. That was independent of socioeconomic deprivation, but also the impact of CGM varied by ethnicity. In fact, those that had the lowest access had the greatest benefit of CGM. And if they started CGM within that first year, basically it eliminated all those discrepancies, all that disparities in HbA1c. So CGM was very powerful in eliminating those inequities in glycemia that we see for diabetes. And it doesn't matter which diabetes conference you go to, what we hear more and more is where we've got funded access, we've got the power to reduce inequities, but instead they're actually widening. And how can we do that as healthcare professionals in reversing that? So now I'm going to change to talk about insulin pump therapy in type 2 diabetes. So there really is, for non-sense augmented pump therapy, which to be fair is the access only pump therapy we have in many countries in Asia and the Pacific, is that there is only mixed benefit versus multiple daily injections of insulin. Saying that, the ASD and ADA still recommend considering it. But we do have to think about the technical differences with type 2 diabetes versus type 1 diabetes when it comes to pump therapy, particularly around the reservoir size and maximum bolus, which obviously when we use much greater doses of insulin in type 2 diabetes, the greater comorbidity burden is really only relevant in the older adults with type 2 diabetes. But we're starting to see more and more data on the benefit of closed-loop pump therapy in type 2 diabetes. And what we did in the Waikato was, this is a first-in-human study. This was fully automated closed-loop therapy, so no meal announcement whatsoever. We chose the Ipso pump. The Ipso pump has the benefit in that you can just change the reservoir without changing the infusion set. So you can imagine for those greater doses with type 2 diabetes, and it was with a novel algorithm. It was only a small study, only 10 Māori and Pacifica patients. It was in older adults. What we did find was a very marked increase in time and range. These were in people already on maximum therapy, they're already on GLP-1, SGL2, metformin, etc. But time and range increased from 10 to 55% with a corresponding reduction in HbA1c, and it was safe. There was no severe hypoglycemia. In fact, there was actually no mild hypoglycemia at all, and no DKA. So here's just the results for every participant, and you can see the improvement in HbA1c there, the median HbA1c reduction close to 3%. One part of that which we are going to be cognizant of in terms of our treatment, when we aim to not use insulin in type 2 diabetes if we can, but it's just around weight gain. And the median weight gain in this trial was only over 12 weeks, was 4.4 kilograms. To be fair, a lot of it we chose insulin deficient individuals, but it is something we will need to watch. In terms of thinking about the evidence in other types of diabetes, once again, there's even less evidence in terms of CGM in these groups. We're all very familiar with the sense augmented pump therapy in cystic fibrosis-related diabetes. I can say anecdotally we've seen a lot less of a need for use of pumps since Trikafta's become funded in New Zealand. But there really is equivocal benefit when you look at non-sense augmented pump therapy in this group. There is potential role. There's very successful case reports in insulin-deficient monogenic diabetes of use in this group. And all as being paediatricians, you'll be very familiar with using insulin pump therapy for neonatal diabetes. So in terms of other technology, because it's just not CGM and pumps. Smart pens have been shown to be effective in type 2 diabetes. The biggest issue, though, is that they remain unfunded pretty much in every country, so that's very hard to get access to, but it does remain an option for people who aren't keen on automated insulin delivery. It doesn't matter what technology you use or what form of contact you use, but there's text messaging and both apps have been found to be very effective in youth with type 2 diabetes, at least short-term benefit. You can debate whether there's long-term benefit. That benefit does definitely wane with time. The biggest issue with apps, though, is around the lack of regulation. In fact, in most countries in Asia Pacific, there is no regulation at all. And you can be wary, and if it is advising you to take doses of insulin, about thinking about the safety in those areas. But it is a potential area that we can work with. That includes data software for both patients and healthcare professionals. They're once again shown pilot studies with clear benefits. But in terms of safety and whole population rollout, it remains a different story from that point of view. One thing COVID did teach us was the increasing role of telehealth in all areas of diabetes care, including type 2 diabetes. It's something we find we have a very large geographical region where I work, and it's something we've started to use a lot more. And one thing is, once you have increased use of CGM, obviously it is changing the way we work in terms of everything being cloud and remote based. And one thing which many centres are also working towards is trying to increase access to retinal photo screening, both through the use of smartphones and AI reporting, which has at least been shown to be initially effective moving forward. And I suspect it's something we'll start to see more and more of. So in terms of the key points, I try to save plenty of time for discussion and questions. Really, I think if we look at type 2 diabetes in particular, and also other forms of diabetes, there are certain groups who will clearly benefit. Not necessarily saying this is a one-size-fits-all, but there is clear evidence for those on insulin, and particularly at diagnosis around education, that we should be considering CGM in these groups. We need a lot more data in youth, but the data we do have suggests the benefits are likely as is similar in older adults. If you attended my workshops, I hope the message you got, the take-home message you got, was CGM is far more than just putting a sensor in. It really is about maximising the education, minimising the distress that CGM can use, and making sure there's a treatment plan for clinical action alongside the CGM. As I said, we try not to use insulin in type 2 diabetes, but sometimes obviously we have to. And it's clear that automated insulin delivery likely may have just as much benefit in type 2 diabetes as in type 1 diabetes, but the algorithms need to evolve. Most of our algorithms have primarily been designed for type 1 diabetes. We will need special algorithms for type 2 diabetes. And our biggest challenge, and probably for everyone in this room, is the lack of funding for diabetes technology. And it's how we can continue to act as advocates, how we can make the most of our access to technology, and how we can reduce inequities in access to technology. It is changing the way we work. We do need to adapt as well as healthcare teams in meeting those needs. I'd just like to acknowledge the rest of the team that's been involved in this work in both the University of Waikato and the University of Otago. But thank you. I'm happy to take questions.
Thank you so much, Professor Ryan. We would like to invite you to sit on the podium, and we'll move on to the next speaker.
So we move on to the next talk. It's my joy and privilege to invite Professor Jennifer Cooper for the next talk. She has been a mentor for me for 3 years while in Australia, supporting me and encouraging me in my pediatric endocrinology learning. Professor Cooper is the head of the Diabetes and Endocrinology Department at the Women and Children's Hospital, Adelaide, South Australia, and she leads the discipline of pediatrics in University of Adelaide. As you all are aware, from the very first plenary lecture that we heard, her major research interest is in the screening and prevention of type 1 diabetes. She is a co-investigator of all the major clinical trials in regard to preservation of beta cell function in type 1 diabetes, and she leads India, a truly fully recruited follow-up of 1,500 children from pregnancy till the development of type 1 diabetes. She is also a co-author for the ISPAD and the JDRFI guidelines on pre-symptomatic type 1 diabetes. Over to you.
Thank you very much, Anna, and thank you again for inviting me. So in this talk, I'll talk a little bit about intervention in early type 1 diabetes to delay the onset of needing insulin, and then a bit more about the trials that have happened in clinical type 1 diabetes once someone is actually on insulin, and finally about the Australian Bandit trial of baricitinib, which I was involved with. The idea of disease-modifying therapy, or immune-based therapy, as we call it now, is not recent. But as you can see from this timeline, the actual use of it in clinical practice is really very recent compared with our paediatric colleagues in rheumatology and gastroenterology and even neurology. And as I mentioned before, there are many targets of the immune system in type 1 diabetes, which is a heterogeneous disease. And we have opportunities with monoclonal antibodies at both the T cell level and the B cell level. We have fusion proteins which interfere with co-stimulation. We have effects directly on the insulin-producing cell itself. And you can add to this diagram GLP-1 agonists as well, which directly affect the beta cell. So first, this early type 1 diabetes that I mentioned earlier in the week, the so-called stage 1 and 2, where there are no symptoms, blood glucose is either normal or starting to become more variable, more dysglycemic, but importantly, no symptoms and no requirement for insulin. The stage 1 studies were long studies, very expensive studies, and the majority did not reach their outcome. So first of all, oral insulin, it was safe as expected, but didn't prevent progression from stage 1 type 1 diabetes in children. A post hoc analysis suggested that children with the highest genetic risk may have had some delay. Hydroxychloroquine study was the only study that's gone right down to children as young as 2. Most of these studies have been over 6 or over 8 generally. As we know, used in malaria, but again, had to be stopped due to fertility. And then abatacept, again, was safe. It's a very safe agent in rheumatoid arthritis in children, and our rheumatology colleagues find it a very safe agent, but didn't prevent progression, although there was a signal of some early effect and preservation of C-peptide early on. So it's still under consideration, particularly for combination trials, which I'll come to. The landmark trial, of course, the sort of breakthrough, if you like, was in 2019, the CD3 monoclonal antibody, teplizumab, for the T cell receptor CD3, showing that after 14 infusions, the delay to requiring insulin was close to 2.5 years. And importantly, that was considered adequate effect for the FDA to approve it in November 2022. So it was the first and is always the only disease-modifying therapy that's currently approved for type 1 diabetes. But, you know, our countries don't have this. It's very expensive. It's in clinical practice to a small degree in USA. I know the paediatricians over there find it quite a demanding treatment. The infusions would require long lines in our younger children, etc. It's a breakthrough in terms of a paradigm shift, but we don't think that's the future. So for stage 2, we have teplizumab, and there's a current study in progress for antithymocyte globulin from the Florida group, which is the only other stage 2 study. Stage 2 studies require a lot of numbers to be screened because you've got to find children at risk who are just at this stage of dysglycemia. And so much of the work for informing stage 2 trials is going to come from our studies in clinical type 1 diabetes stage 3, which is obviously a much easier time to recruit participants because they're coming to us as our patients requiring insulin. So it's so-called stage 3. And these are some of the main agents that have shown promise in preserving C-peptide production and beta cell function. And you can see there some of the agents, the monoclonal antibodies, a low-dose antithymocyte globulin, abatacept, and we'll talk a little bit more about baricitinib. The treatments were set up ready for a year and are either a series of infusions at the beginning or intermittent infusions or subcutaneous injections. Baricitinib was oral, and I'm not showing verapamil, which was also oral. But I think what's interesting is you look at the maintaining the C-peptide level and stopping it from falling, it was generally only for about 6 months. So after that, there might have been a difference with placebo effect, but it starts to fall away. So holding endogenous insulin production at the baseline level or a little above was usually only for about 6 months with all these agents. There's been attempts to rank them, and Laura Jacobson and the ones in blue put together a sort of analysis and correcting for the different laboratory C-peptide levels and came up with teplizumab and ATG as the biggest increment, and then baricitinib is close to that, and verapamil, the two oral agents, but they weren't part of that analysis. Interestingly, there's been no significant serious adverse effects, but these have been phase 2 trials, the big phase 3 trials. There's been teplizumab PROTECT study was large, but we haven't had a lot of data on safety, and most of our data we're really taking from rheumatology, in particular data in children for safety. One question people have asked is, now that we can achieve such better and close to target glucose control with automated insulin delivery, does that preserve C-peptide production? And I think the answer is fairly definitely no. The earlier study in the bottom from the Cloud group actually was a few years ago and only held the time and range to about 65%, but with the most newest commercially available systems of automated insulin delivery, and the holding them at 82% over the 12 months on average and 78% at 12 months time and range made no effect at all on C-peptide production. So I think we're pretty sure that even though we love automated insulin delivery, it's not affecting C-peptide. The benefit of C-peptide production being preserved, even to a small degree, has been recognised for a long time. So this is the Diabetes Control and Complication trial that some of you will be old enough to remember in the 1990s. And they found that so-called responders, these are people who had C-peptide levels at a level of 0.2 nanomoles per litre or more. So that's not a particularly high level. It's the sort of level we require usually entry into immune modulation trials. So 0.2 nanomoles per litre. But those people who sustained it over the course of DCCT had significantly lower risk of retinopathy, significantly lower risk of severe hypoglycemia, and this was independent of their hemoglobin A1C levels. So a small amount of C-peptide goes a long way if sustained. So there's been a lot of interest in the evidence for C-peptide as a surrogate for clinical benefit, because no approval regulatory agency is going to approve disease-modifying therapy with C-peptide as the outcome if they can't see clinical benefit. And I'll come explain soon why hemoglobin C doesn't usually change in these trials in the first year. And this was a recent paper brought together looking and showing that clinical benefits are occurring, particularly in hemoglobin A1C and hypoglycemia. And another related paper showed approximately 25% greater C-peptide, you decreased hemoglobin C by about 0.6, and once you get to 75 preservation levels, really with almost minimal insulin, you really get optimal glucose targets very easily. So as I mentioned, combination therapy is probably the way to go, keeps with multiple targets, but we're still a little like guessing for an individual participant what those targets should be. We have no sense of personalised medicine yet, but combination therapy trials beginning. This is a trial in Australia which is currently recruited in 6 to 25-year-olds led by John Wentworth, and recruited very well and quickly, and every child gets abatacept, a weekly subcutaneous injection according to their size, and they're randomised intranasal insulin or not. Another combination therapy trial and process is the young adults from TrialNet, and everybody gets rituximab infusions at the beginning and then is randomized to addition of abatacept. So increasingly, these trial designs have everybody having some active agent and then adding another one on for the combination effect. And the third combination trial, which has just started, is TID Plus from Colin Dan's group in Cardiff, where verapamil is added to either low-dose antithymocyte globulin or baricitinib or globimab. It's a platform trial therapy, and it's just started recruiting. So now the Australian Bandit trial. It was a phase 2 trial investigating the efficacy of baricitinib, a JAK1/2 inhibitor in new-onset type 1 diabetes. The Janus-associated kinases, JAK for short, transduce cytokine signals that are involved in inflammation and adaptive immunity. And in this diagram, the yellow oval is the cytokine attaching to its receptor, which by phosphorylating that receptor from the JAK kinase, you allow them to signal the transducers and activators of transcription downstream. So you get the sort of cascade of events, and that's what the JAK kinase inhibitors interrupt. So JAK inhibitors have been used to treat a number of autoimmune conditions. The rationale for using the isoforms 1 and 2 in type 1 diabetes came from the laboratory of Professor Helen Thomas and Professor Thomas Kay, close colleagues and friends. And this is just a video of the beta cell and the green T cells and a flush of red cytokines. And when you add in the JAK1/2 inhibitor, you interrupt that process. And then you can see in the experimental NOD mouse model, you reduce the risk of progressing to type 1 diabetes quite substantially. In histology, you're staining there for insulin at the top and CD4 and CD8 cells. So you can see the effects are quite marked in experimental models. So we set off to determine if baricitinib 4 milligrams daily for 48 weeks in patients 10 to 30 years with recent onset type 1 diabetes, preserved C-peptide. It was across Melbourne and Adelaide. And I'm just showing you this slide because this was in the middle of COVID. Melbourne was one of the most locked down cities in the world during COVID. And we had a very good recruitment and 2-to-1 baricitinib to placebo and very low withdrawal. I don't know if it was all because we were in the same place, locked down, but it was interesting because we weren't anticipating this. Recruitment rate across 2 pediatric, which were the main centres, and 2 smaller adult sites, was more than estimated. And the primary outcome was C-peptide reduction at 1 year, and oral baricitinib was effective with an increment of close to 50% from placebo at 1 year, which we're very pleased about. Just putting that in relation to that level I told you that sustained gives clear clinical benefit. This is, of course, only over the first year, this level. And in addition to the C-peptide level being higher, insulin dose was lower in baricitinib. There was no difference in hemoglobin A1C, and that's usual because we're all treating to target. These are patients that are given very good care, seen very frequently. We used to ring them every 2 weeks. So they're and given automated insulin delivery, etc. And that's one of the issues with these trials is hemoglobin C generally isn't an outcome that we can change in the early days. We used continuous glucose monitoring data as well. The coefficient of variation was decreased by baricitinib, and the time and range was increased as we anticipated. Looking at the effect of baricitinib on some of its mechanisms, baricitinib, as expected, reduced phosphorylated signal transducers and activators of transcription, both basally and stimulated, and also, as expected, as you can see by the asterisks there, that's the phosphorylated stats coming down, and then the effector memory CD8 T cells also reduced. But you can see considerable overlap here. So preserved beta cell function to the level of best available agents, and all of them at this time were infusions or subcutaneous. So this was the best effect of an oral agent. Decreased requirement, improved metrics, and was well tolerated. There was a small increase in incidence of acne in the adolescents, which has been described with baricitinib, but no other effects of note. Now, after we stopped baricitinib at 12 months, some of the families wanted to continue, interestingly, but we carried on with the trial without any treatment in year 2. And you can see, as for other studies, once you stop, things start to shift the effect, fade effect. The hemoglobin C hadn't been abnormal different anyway. The insulin dose came up to the placebo group, and looking after these patients, we could feel this was happening, even though we were blinded, obviously. If you look more closely at that insulin production after 12 months off treatment, it's still significantly different at 2 years, but it's obviously falling with the placebo group, which means that these types of agents will need to be continued, which, while they're very safe in the short term, does put another view on it, I think, and perhaps the need for a sequence of modifying therapy rather than just continuing one agent. Continuous glucose monitoring metrics also change back closer to placebo over time. Time and range fell back closer to the placebo group, and likewise variation. So next steps, discussions with Eli Lilly for a phase 3 trial, which would be required probably for regulatory approval. We're very interested, as certainly as paediatricians, to get down to the younger children. Very few, well, there are no studies at the moment for children less than 6. There was a tiny study looking at Sanofi's looking at teplizumab, but at the moment there's really very little for these young children. We know they're the ones that progress very quickly. They may actually be very responsive to intervention, and that would be great to have a trial designed to bring them in. And also, obviously, to bring it back to the pre-symptomatic stages. If it's effective in stage 3, would be optimistic it'll be effective in stage 2. Combination is going to be important with completely different agents, such as a tolerizing agent or even verapamil, its direct effect on the beta cell, and perhaps some other JAK inhibitors have shown promise experimentally. JAK inhibitors are well tolerated in younger children. I went to see my sort of rheumatology colleagues and was helped on this area. There's some rare autoimmune inflammatory disorders that some of you may have already seen and looked after in infants from 6 months, which baricitinib is used for. Some of the JAK1/3 inhibitors are used in juvenile idiopathic arthritis down to 2 years of age, etc. So there's quite a lot of experience in children with JAK inhibitors. The FDA approval reflects this, and baricitinib actually was the one used for COVID emergency authorization for pneumonia down to 2 years of age. And these agents, the JAK1, JAK3, baricitinib and ritlecitinib, are currently part of a type 1 diabetes trialnet trial recruiting at recent onset, which we're also involved with quite a clever name called Jackpot, which I thought was... So just finally, off-label prescribing was something that we started to realise we might be faced with inquiries about, and while we didn't really want to get into this game, we thought it was better to sort of look at it head on in Australia and try and write down some recommendations. Because these are agents that are certainly available in Australia for other conditions that have shown some benefit in preserving beta cell function. And we had a period where there's usually one sort of recent onset study going on in our unit, and there was just a period when there wasn't, and so some children just sort of missed out. You needed to have a C-peptide level above 0.2 nanomoles per litre. You needed to be within 100 days of diagnosis. There's always those families that get close to coming to a trial, and then something happens that they can't. And so these are some of the, I think we all know as paediatricians how what a difficult time it is at diagnosis. It's an incredibly vulnerable time to be recruiting for studies. So many families are looking for something to help, looking for something they can control, I think, too, a diagnosis of type 1 diabetes. And these are the families that, some of them, my patients who you can see, are really grappling with the idea of not being able to be part of a study that is going on in our department, and is completed recruitment, etc., in the real world. So we put together these recommendations for off-label prescribing. Interestingly, when we were looking at the ISPAD guidelines recently, I was asked to look at this paragraph, and then it was completely taken out, because I think the consensus was we shouldn't be looking as though we're in any way recommending off-label prescribing. We just thought in the real world it was useful to have some guidelines if this was going to happen at all. We're recommending that it occurs only in settings where the outcomes and adverse reactions can be carefully monitored, and indeed read the centres which are already probably involved in clinical trials. You want to make sure there's adequate residual beta cell function. This is an important point. Really, all trials require participants to have fasting C-peptide greater than 0.2 nanomoles per litre. If you've really got very low C-peptide levels, it seems unlikely you're going to have much to preserve and respond. There has to be safety considerations. You need to look at therapeutic effect early, by 6 months. Ideally, all data will come to a national repository. And of course, there's the whole issue of costs and inequity of access, which concerns all of us. So in summary, the future ahead of us, putting a few little things more over and above this talk today. General population screening is certainly coming for some countries. It's already come to Italy. Primary prevention initiatives, hopefully this year and in 2 years' time, we'll have some of those trials coming through, and maybe we'll have some prenatal ways of interfering with things like the gut microbiome. But I think it would be very optimistic and consider that will reduce incidence by even 20%. It's thought that viral etiologies may account for maybe 8%, something like that. So you can sort of see that is not going to be the full answer. We're increasingly thinking of our early stage children going into clinics, some by telehealth, and looking at best ways of delivering that type of care to children that don't require insulin, personalised and combination immune-based therapy, and maybe a sequence of immune therapies looks like the way to go for the future. And with our sort of goal to keep requirement for insulin prevented, if we could push type 1 diabetes right out to even young adulthood, that would be wonderful. Or to keep the insulin dose as low as possible. I think most families would choose a small once-a-daily dose over even automated insulin delivery systems, or to keep automated insulin delivery systems with low doses as simple as possible. I just want to thank the Bandit team, particularly the group from St Vincent's Institute, from which this whole underground science brought this Australian story together. And finally, our wonderful families. Thank you.
Thank you, Professor Cooper, for that very exciting, and it looks quite promising in the future. The floor is open for questions to all three speakers.
Wonderful talk. The first question is for Professor Joseph. This I want to know. You see a lot of neonatal diabetes. So here we also have, in India, we have a lot of patients with neonatal diabetes we're picking up. So because extra takes 4 weeks to give the results. We have a genetic center here also in Chennai, where it takes around 3 to 4 weeks for results to come in. So have you ever tried in your, in experience, of using sulfonylurea without getting the results? The results for the test for neonatal diabetes, the genetics. Before the genetics, have you ever used sulfonylurea before genetics come in?
Professor, I think what he meant was trying to use sulfonylureas before your genetic test becomes available. Am I getting that correct?
Yeah, that's it.
Okay, that is interesting question. Thank you very much. Some centers, some experts tries to use combinations, insulins and also sulfonylurea after diagnosis of neonatal diabetes. Yes, but in our case, it's just after confirmations, we transfer from insulin to sulfonylurea.
So you keep on giving insulin for 3 months, 3 weeks, 4 weeks, and then wait for the results to come, then shift to
And then
sulfonylurea.
we transfer. Yeah.
But it's a long time the patient keeps. They know the insulin. They don't respond to insulin. They never have good control.
Yeah,
of
because
insulin.
it's many causes. It's not only potassium channel cause neonatal diabetes, but based on clinical symptoms. For example, normally it's a potassium channel mutations. It's symptoms we present later than INS or transient diabetes. Transient neonatal diabetes normally is presented during first weeks of life, and also you can see birth weight is lower. And in our case, it second or 3 week or 2 months, we sometimes we combine with insulins and also sulfonylurea.
So what we are doing in our center, I don't know whether it's applicable or not, but what we do is we give them the dose of sulfonylurea and get the C-peptide done after 2 hours of giving the dose of insulin. So most of the time the C-peptide is rising.
Okay.
So that's there are now some studies which come up which show that the C-peptide is rising.
Okay.
You can go on ahead with the use of sulfonylurea and along if insulin, and most of the babies they respond to this sulfonylurea.
Okay.
And by 3 weeks you'll get the result from Exeter. Exeter takes time, all this, because we started many samples we are sending to Exeter London, but it takes time.
Yeah, we started with low dose, 0.1 milligram per kilogram per day. And normally we ask the patients to admit it as inpatient. But protocols for our patients is different and longer, but we have to pay attention of hypoglycemia.
Yeah, thank you. I have one question of Professor Rayan. I just want to know, are you taking any consideration, because CGMs, we are doing a lot of patients, and there is always a difference in the CGM versus the blood glucose glucometer, 20, 30, 40 also the time, especially in younger kids. So are you making any cutoff that which value of CGM you must do a blood sugar check always, like in for hypo or for hyper?
I think it depends on the
Like
situation.
your voice, and it's not coming.
You hear me now? Yeah, so I think it depends on the situation. For example, if they're not on insulin or sulfonylureas and it's type 2 diabetes, then I wouldn't worry about hypoglycemia necessarily. It's not going to be meaningful. If they always have a mismatch between symptoms and what the CGM reads, there is a time to do a blood glucose level. So the most common situation for that, probably the CGM will read low. There's no symptoms of hypoglycemia. Do a blood glucose level at that point. But otherwise, with the newer CGMs, they are all approved for treatment regardless of blood glucose level. In those situations, generally they are valid, but it's that mismatch is the major time to be checking blood glucose levels.
So do you find it different between using Dexcom or using Abbott Freestyle, or as far as the terms of the management is concerned in different types of CGM?
Well, with the newer models, I find it's much of a muchness. They're much more accurate in the hypoglycemia range. Initially, particularly the Freestyle Libre 1, it was, you did worry about it anecdotally in the hypoglycemia range. That's much less of a worry with later models. But if you're ever suspecting that it's not true hypoglycemia, there is a time I'd check the blood glucose level.
Okay, thank you.
I'm Musa from Ireland, and my question is to Professor Ryan. It was a very wonderful talk regarding mentioning about the role of technology. My question is whether you have any studies done on the role of technology in gestational diabetes, which is one of the more arena where people are advocating automated insulin delivery for these ages.
Yeah. I haven't done the studies myself, but it's very good literature showing that it is effective. In fact, arguably that's the group that's the most cost effective, just in terms of the amount of test strips they're going through in terms of monitoring blood glucose levels. So that is a group we're very strongly advocating for CGM in. We know that automated insulin delivery is also effective in this group, but there is limitations in terms of what's approved in diabetes and pregnancy, but that's more for type 1 diabetes. Purely for gestational diabetes, the key evidence is around CGM.
Thank you.
Thank you, Joseph, for a very crisp talk. I'm Dr. Ravinder from Delhi. So I have two questions and one request for you. So first question, one of your case was very interesting. He landed up in DK with coma with 20% of HbA1c. What finally happened to that case? I was just wondering, which you showed one of your cases was although having for 2 months polydipsia and polyuria, but still he landed after 2 months and with such a severe situation, DK 21, HbA1c of 20 and in coma. What happened finally to that case? Are you able to save that patient? What is the final outcome of that case?
Thank you very much. Interesting case. When I send samples for confirmations of modified, our experts in UK was surprised why I could make diagnosis clinically, because it's when admitted, blood glucose level was so high, and also HbA1c was 20%, but it's my clinical symptoms. And after stable, after condition, his conditions was stable, and kidney function still is not improved. That's why we move for ultrasounds and abdominal CT scan, and identifies no bodies and no tails of pancreas, and then we confirms modify. But now he's fine, but he needs hemolysis every week.
Okay, thank you. And second, you just mentioned about the GCK, as you said, that doesn't require any treatment because it is having just mild fasting hyperglycemia. And what about those cases when if she's a girl and having pregnancy, I think in that situation, they require some sort of treatment.
According to my understanding, reviews in 2024, yes, it's less evidence. It's not enough evidence to show no need treatment. But some groups, they found that it's low carbohydrates is better than high carbohydrates, but still very weak evidence.
Okay, and this is just final statement. And this is on a very lighter note. Please don't take it seriously. But your team is too beautiful, sir. Too beautiful. I would love to join your team, sir. No one is having that team.
Thank you.
So one question for Dr. Ryan. You had shown in that data, if I saw it correctly, that in type 2 diabetes, when you used automated insulin delivery, then there was a weight gain of 4 kilos. So actually, I think it's a real concern because they know that whatever they eat, the pump will take care automatically. And probably, do you think something similar would be actually to be expected in children with type 1 diabetes also, who are put on automated, especially when we know adolescents and obesity is a real risk?
It definitely is a concern. To be fair, though, some of these people were actually quite insulin deficient, so that weight gain was to be expected, regardless of whether it was automated or by MDI. Personally, I always try and leave insulin as the last treatment for type 2 diabetes for weight gain as being a big part of that. So I guess we haven't done the studies in children in terms of automated insulin delivery in that group, but it's definitely one thing I'd encourage people to watch.
Yeah. And just one small question for Dr. Cooper also. So like you mentioned that some parents approach you for some form of experimental or even off-label treatment when their child is newly diagnosed. So we often face such queries also. So like if we explain to them fully that it is all experimental, but is there something oral that maybe we could try, like verapamil? Would it have any role?
Yeah, thank you. It's obviously, it seems a much easier thing to have an oral agent, especially if it's off-label. And verapamil, in the studies, there was a benefit, but it was relatively small. It was just under 30% increment, which then fell away. There has been some publications on its use in US, sort of off-label. And while it is basically a safe agent, that there was one child who actually went into heart block on it that I think was survived, but it was, not
I understand,
not
yeah.
a pleasant situation. So I think we sort of see verapamil perhaps more as a combination agent without having the proof of that, but it's certainly in the recent type 1 diabetes relay study that's its use, we think.
And there's no other oral agent.
Well, there's obviously baricitinib, but we've put out those kind of recommendations because we're having inquiries, but we weren't recommending it as such. Yeah.
Thank you.
Thank you. Good morning. I am Dr. Sanjay Badada. So my question to Dr. Paul, that you said that in type 2 diabetes, young type 2 diabetes, thiazolidinediones are not indicated. So is there any specific reason for that?
I think it's more depending in terms of the level of efficacy and safety data in that group. I'll be honest, the older group, particularly those that are adults themselves, I've personally found pioglitazone quite useful in some, but you're just being wary of the lack of data in that group.
Yeah, even if you go by the accelerated hypothesis, and with that the onset of type 1 diabetes early in the obese individuals, they do have some insulin resistance, and thiazolidinediones are supposed to improve the insulin resistance.
Yeah, also I think it's being aware that these people are a different group. Like for adults, for example, DPP-4 inhibitors are useful, but they're not in youth. We know that GLP-1 receptor agonists don't have the same glucose-lowering effects in youth compared to adults. So there is different physiology, and I can't exactly give you I don't know if the exact mechanism is known why thiazolidinediones don't work as well in youth as they do in adults.
Maybe one thing is that because jolidins are known to cause affect the bone mineral density, so may it be interfere the peak bone mineral density. That may be one of the factor that may be.
It's always one thing that we worry about. That's correct. Yeah.
Okay. Thank you.
Are there no more questions? I have a question for Professor Cooper. Given that, this sounds very promising, the baricitinib therapy, and how do you decide on when you will intervene in the pre-symptomatic cases, because of this extreme heterogeneity from the onset of islet antibodies to a symptomatic phase? How do you decide when you will intervene? And the second question is, off-label therapy, how do you decide the duration? When do you stop? When do you continue?
Really good questions, Anna. And so first of all, when do you intervene? I guess the one effective intervention before clinical type 1 diabetes was in so-called stage 2. But even within stage 2, we sort of recognise factors that make you more likely to progress. And most people now, when designing a trial, would want to at least have a risk of in 2 years of 50% progression to enter, because what we want to avoid is these long drawn out studies that were exemplified by the stage 1 studies, where very expensive, probably a very heterogeneous group of children in terms of when they're going to get type 1 diabetes. We know that the vast majority are going to get type 1 diabetes sometime in their life, but that could be 10 years away or 10 weeks away. So very good question. Some of the things that seem to be helpful in addition to knowing someone's in stage 2, is to look at the hemoglobin C. 5.7 to 6.5 is the same as type 2 diabetes, really interestingly, is seen as an important risk of progression within 2 years to insulin requirement. And actually as oral glucose tolerance test as well. So that sort of level of 7.8 to 11.1 millimoles per litre, not quite ADA clinical diagnostic levels, but at 2 hours, certainly above 7.8. Continuous glucose monitoring is being looked at, but it really yet hasn't come up trumps, because I guess clinical glucose monitoring is sort of frequency rather than accuracy, and we're trying to get percentages over a certain threshold, such as 7.8, and risk of progression. The Denver work suggested 10 to 20%, but it doesn't seem to be always coming out that way. So I think for trials, we're going to use OGTT and hemoglobin A1C. And the second question, how long? I think that's so that's such absolutely, that is the issue. But someone, e.g. baricitinib, it looks as though you'd probably need to continue this. So exactly, that's why we're unhappy about off-label prescribing. It doesn't really make sense to set someone off on a course like that without prior evidence for the long term.
Thank you very much. I will close this session now.
I thank all the speakers for their enlightening talks and sharing their experience with us. I thank the chairpersons for guiding us through the sessions. I would now request Dr. Anju Seth and Dr. IPS Kocher to felicitate the speakers and chairpersons at the felicitation point. Request Dr. Smriti and Dr. Anjali to please accompany them. We will break for tea now, and this will be followed by oral paper presentations in the halls on the second floor. Thank you. So oral paper presentations will start at 11:30 sharp.